Myself, Dr. Anand Shukla, Professor in Cardiology, UN Mehta Institute of Cardiology Department. Today I will share my view regarding the evidence what are the radial SS complications. Nowadays the major procedure has been done through the radial artery due to advantage over the femoral, but it also carries some complication, so we should know how to deal with or treat this complication. If you see the incidence, the major vascular complication is 0.2% and major overall bleeding is 1%. So if we divide the radial SS complication either during the procedure or post procedure. During the procedure may be bleeding, there may be due to radial artery perforation, non-bleeding, that is radial artery spasm, radial artery dissection or catheter kinking. Among the radial artery spasm, rare complications are traumatic eversion or catheter entrapment. In post procedure, either bleeding or non-bleeding related, bleeding related forearm hematoma and compartment syndrome, non-bleeding related either radial artery occlusion, that is symptomatic or asymptomatic, pseudoaneurysm formation, AV fistula, nerve damage and infection. These are the various trials from which the major and minor complication rate ratio has been derived. So I am not going into detail in the various trials, just simply start with the enumerate the one by one the complication, that is the radial artery spasm, traumatic eversion, catheter entrapment, any radial artery loop, how to overcome the loop with the balloon assisted technique, bleeding perforation dissection, radial artery occlusion, radial artery pseudoaneurysm, sterile granuloma, hand damage, AV fistula and non-occlusive radial artery injury. Foremost, most common is the radial artery spasm. Diagnose. How to diagnose? There is a temporary sudden narrowing of the radial artery. It is because of abundant alpha adrenoreceptors. It immediately lead to the head discomfort. Patient will complain of the pain, even minor movement of the catheter. While resistant to advance, all withdrawal of the catheter, that is one of the signs for radial artery occlusion, spasm. That may lead to catheter or sheath entrapment, that is less than 1%. Now, if we forcefully withdraw, then radial artery eversion may occur. So one should avoid the forceful withdrawal or the pushing. Incidence is 4 to 20% and severe spasm is around 2 to 7%. The major reason for the radial artery spasm is the small size radial artery, or if we have used the larger sheath, 7 or larger, then that lead to, usually majority we use the maximum the 7. Excess catheter manipulation, women having more chances, smoker in more chances of radial artery spasm. Anxiety for the procedure also lead to the spasm. Vasodilator not administered after the radial artery puncture, that is cocktail, NTG, verapamil or dilsem. Use of intravenous vasopressin. Suppose we have taken the patient for the procedure and patient on high dose of inotrope, that is a NORAD or anything, that lead to the radial artery spasm. And repeated puncture. If you are not able to get the radial puncture in the one pick, then chances of spasm is the. So prevention is the most efficacious way to prevent the complication. The meticulous radial puncture, single puncture or ultrasound guided, administration of vasodilators, there is nitroglycerin, dilsem or verapamil, thin wall sheath, that is a turmo sheath, usually radio focus sheath majority of time we are using. Don't use very small radial artery. Whenever you find the radial artery pulses are the feeble, not good volume, to avoid the radial artery as a site of catheterization, avoid excessive catheter manipulation. That's why we are doing the angiography from the single catheter. Adequate or moderate sedation, local anesthesia. Sometimes some suggest a long sheath, but it has not proven. A sheathless guide. During the therapeutic, we may use the sheathless guide to avoid the radial artery spasm. Treatment is a vasodilator administration, that is a nitroglycerin or verapamil. We can inject a NTG even locally. Sometime if you are not successful, then propofol for the short general anesthesia. Warming of hand, Then if you increase the temperature by the blanket or the massage, one can increase the temperature of the head. Administration of the lubricant solution, Rotaclide or Viperclide, ischemia-mediated vasodilation. We can inflate the cuff over the above the systolic pressure for the 5 minutes. That ischemia lead to the radial artery vasodilation. Forceful withdrawal one should avoid. Once artery spasm is there, forceful withdrawal or maneuver of the catheter should be avoided. So the radial artery spasm, this flow chart, there is a puncture-induced radial artery spasm, non-pharmacological forearm eating, BP cup, ischemia-mediated, pharmacological, NTG, subcutaneous or per oral, minimize the radial artery injury by the ultrasound guided puncture or cylindrical tankering. Forearm manual heating using the operator's palm, that is a ball-based maneuver for 3 minutes. Warm compression using surgical towel or blanket or warm water. Flow mediated sphingometer cuff, apply in the mid upper arm, inflate for 30 mm Hg above the systolic. Suppose patient pressure is systolic blood pressure 120, then we can increase the systolic pressure up to the 150. Pharmacological NTG, that is 100 to 200 microgram intra-arterial, verapamil, dilzam, nicardipine, these or. Oral nitrate, we can give sublingual nitrate, subcutaneous NTG injection or lubricant, that is a Rotaclide we can use. Intra-procedure, if mild radial artery spasm, sedation and spasmolytic, moderate to severe radial artery spasm, that is the analgesia first line. Spasmolytic, if first step is not successful, then flow mediated, there is cough, warm, increase the temperature, forearm eating, subcu NTG, Rotaclide. If second line is not work, then third line deep sedation, general anesthesia, axillary nerve block. These are the way to overcome the radial artery spasm. These are the artery with forceful withdrawal, then radial artery eversion may occur. So avoid the forceful action. Sometimes catheter kinking occur due to the radial artery spasm. We have to cut the catheter hub. Then we have to introduce the long sheet up to the kinking level. Then gradually withdraw. These are the method for the given radial artery spasm. When bleeding occurs, bleeding due to challenge in the hemostasis or vessel perforation, radial artery perforation are rare, less than 1%, dissection with without major bleeding. Infrequent, manifest as a local hematoma and pain, vasovagal reaction and hypotension, may lead to compartmental syndrome. Etiology, causes suboptimal placement and compression. Suppose we have done the radial artery puncture and we inadequately press the puncture side. Higher the anticoagulation, guide wire entry into side branch. Majority time the inadvertent guide wire enter in the small side branch and lead to the perforation. Avulsions of the side branch, rupture of the radial artery during aggressive maneuver, and aggressive manipulation of catheter through loop. Suppose loop is there, we aggressively maneuver, that lead to the bleeding. Prevention, meticulous assess technique, close monitoring of radial artery access site, careful placement of compression. When we have to compress the radial puncture above and below carefully, not forcefully. Never force guide catheter against resistance. Confirm the correct position in X-ray, always fluoro. Avoid insertion of larger. If radial artery appears small, 6 diameter, then insert the sheath of the 5 only rather than 6 or 7. And balloon assisted technique that we have described previously. So balloon assisted technique, tip of the catheter, we inflate the balloon and negotiate. Rather than keeping the catheter itself, it will abrade the radial vessel. So balloon assisted technique will be helpful. Bleeding, SSL bleeding, reposition, compression device, we have to compression device, second compression device or manual compression of blood pressure cuff. Proximal bleeding, wrapping of the hand in the compression dressing or ice. So ice and reposition of compressed device is most important. Radial artery perforation, how to manage? That radial artery perforation lead to the bleeding. So how we can manage? If the wire proximal to perforation, if our wire is already there, the seal perforation by balloon or the long sheath, continue plan procedure, perforation resolve by itself and checked in final shoot. If not, then protamine and hemostasis or proximal BP cuff. If our wire is not proximal to the perforation, then protamine, hemostasis, compression bandage, prolonged balloon implantation, surgical consultation, and close post-operative follow-up for the hematoma. These are the way to manage. These are the grading of compartment syndrome: 5 cm, 10 cm, and forearm. Depend on the severity, we have to treat. If it is large, then we require the surgical incision. Sometimes compartment syndrome is second figure 3. We can introduce the manometry here. We can measure the pressure. If the pressure is exceed forearm pressure is exceeded 100 mmHg, then definitely the skin incision required. Radial artery occlusion. Most common post-procedure complication less than 1 to 33% vary during the timing of assessment. Meta-analysis of 66 study over the 30,000 patients. The incidence vary from 1 to 33%. Asymptomatic may be painful. Duplex sonography may require. These are the incidence of the radial artery occlusion over the period, because initially it was the learning curve. Now everybody expert in the radial artery intervention. The risk factors are the female gender, low BMI, elderly patient, diabetes, previous radial artery occlusion, ethnicity. Ethnicity is where the low build is the ethnicity. Procedure: insufficient anticoagulant, short seat to artery ratio more than 1, repeated radial puncture, spasm, and aspirin. Post procedure: occlusive hemostasis, prolonged hemostasis, spasm. These are the various risk factors that lead to radial artery occlusion. The small size radial artery and large cyst, if inserted, then chances of occlusion high. Non-patent hemostasis. I will describe in subsequent slide what is the non-patent hemostasis. Absence of low procedure ventricular. We use the less heparin. We are tending to use the less heparin during the radial procedure, but we should use the standardized protocol. Repeat access after radial artery. These are the major reasons for the radial artery occlusion. Meticulous, how to prevent? That is meticulous access technique, adequate anticoagulant, limit duration of compression less than 2 hours, use patent hemostatic technique to prevent the radial artery occlusion, use distal instead of proximal radial artery. So, if you go distally, then chances of radial artery occlusion less, and Allen and Barbie test not predict the radial artery occlusion. Treatment: most patients are asymptomatic, anticoagulant analgesic for the pain. Percutaneous reconnaissance has been attempted with highly selected case, but is not recommended. What is the patent hemostasis technique? If in the left side of screen, if you see the radial artery and ulnar artery, the radial artery has been compressed by the manual compression in the oval shape. The ulnar artery is the circular. So occlusive hemostasis, we completely occlude the radial artery and keep the ulnar artery open. But occlusive hemostasis, the chances of radial artery occlusion 5 to 25%. Reduce the hemostatic pressure and time. So duration of radial artery compression, we have to keep the less. While how to achieve the non-occlusive in opposite diagram, prophylactic ulnar artery. We have to compress the ulnar artery, then compress the radial artery. That will prevent the radial artery occlusion. 3% of radial artery occlusion is standard patient hemostasis if we only compress the radial artery, while only 9% if we follow the patent hemostatic technique where the ulnar artery has been occluded. So these are the steps. Remove the arterial cyst only 2 to 3 cm. Place the hemostatic device 2 to 3 mm proximal to skin entry of the radial cyst and inflate it. Allow the cyst complete the remove. Lower the pressure until some minute visible blood coming through the puncture site. Then re-encourage. So suppose we inflated the bulb for the 12 atmosphere. Then gradually decrease the amount of air till some oozing occurred. Then again slightly increase. Assess the radial artery patency by using the reverse Barbie test. Place the plethysmographic sensor on the index finger of the upper extremity from where the radial artery puncture has been done. Then compress the ulnar artery of the same limb and we can see the plethysmography. Absence of plethysmography wave indicate there is no anterior flow in radial. So we have to remove or decrease the pressure of radial artery compression till the index finger show the compression waveform. So these are the cath lab, waiting room and ward. These are the steps. patient on table, what to be done when it was sheath removal area, and what to be monitored on the ward. These are the steps. Recommended, these are the steps, same step has been described in this table. Another complication, radial artery pseudoaneurysm. That is a pulsatile mile over the radial artery. Sonography is the diagnosis used to diagnose the pseudoaneurysm. It due to multiple puncture, larger size, aggressive anticoagulant, suboptimal hemostasis. These are the causes of the pseudoaneurysm. Meticulous assess. Single puncture is the best for any complication. Don't use the small radial artery and use the smallest possible sheath or sheathless guide. Radial artery pseudoaneurysm management, most thrombus spontaneously, do not require treatment. USG guided compression may be tried, thrombin injection, but here is the palmar arch. We never know whether the thrombin go in opposite direction or not. Endovascular cover stent has been tried in the literature, but these are not. Compression is the only or the surgical. Radial artery sterile granuloma. Diagnosis, there erythematous nodule with sometimes sterile discharge over the radial access. Clinical diagnosis after exclusion of infection can sometimes lead to delayed pseudoaneurysm formation. These are the sterile granuloma picture. Radial artery granuloma, foreign body reaction to the polymer of the radial sheath, more common with the earlier generation. Nowadays is less common. Prevention, avoid use of older generation sheath. Treatment is usually self-limiting, sterile cream application, and sometimes surgical excision required. Hand in dysfunction. Increase in hand volume at the 2 week by 63% of patient, and by 6 months 66%. Sometimes patient may come like he feel the right, whichever arm has been used for the radial artery, it becomes the slightly heavy. Disability, grip strength changes, power loss, or any other hand complications occur less than 0.5%. Next is AV fistula, extremely rare, 0.08%, swelling and pulsatile 3. Sonography used to diagnose. Treatment is conservative or prolonged compression, uses hemostatic band, PTA with the cover stent, or rarely surgical. Non-occlusive radial artery injury, radial artery dissection of wall hematoma, intimal tear, pain, conservative management usually. So sheath to artery, these are the various sheath size and what are the artery diameter or Doppler we can decide. The summary, the prevention is better than cure, proper sedation and local anesthesia to be given. Meticulous puncture, single puncture attempt is most important. Artery to sheath proper ratio is the thin wall sheath to be used. Adequate intra-arterial vasodilatation, adequate, not over, not under anticoagulant. Stop when encounter resistance during the J-wire or catheter manipulation. Do angio to understand the cause. Avoid multiple catheter exchange and manipulation. Proper pattern hemostatics. Thank you.